Okay, so today we look at generalized uniform radiolucencies. These are specifically of the jaws and the calvaria. I'm Dr. Kihara. So welcome to the lecture. So this is the outline of our lecture. We look at the general radiological features of a normal jawbone and radiological features of uniform radiolucency, and then the differential diagnosis and differences. So the image shown is for you to remind yourself about the normal appearance of the mandible and the maxilla. So looking at the mandible, so it is composed of a trabecular bone. We have the trabecular bone and the cortices. So let's get the cursor there. Get a pointer. Okay. Fine. So that's the mandible. So the mandible is composed of a trabecular bone, and you have the marrow spaces. So the spaces are smaller, the marrow spaces are smaller, and the trabecular bone, it's smaller in the maxilla, but they are larger in the mandible. And then we also have the cortical boundaries. For example, the inferior border of the mandible there, we have the cortex over there. This is of a normal bone, and the cortex goes all the way. And then looking at the maxilla, look at the maxillary air sinus. You can see the bony wall. We have a cortical bone there, cortical bone there. So these are the ones which are affected by those systemic diseases that affect the density of the bone. This is our closer view. So you can see the mandible there, you can see the trabecular bone, and then you can see the dark areas or the radiolucent areas. That's a bone marrow. So it's surrounded by trabecular bone. You can also see the inferior mandibular nerve canal. You can see the tram lines. That it also has corticated boundaries there. Okay. And then the inferior margin of the mandible, you can see it clearly there, mid of a compact bone. So that's cortical bone. The same thing here. Here we are seeing a normal mandibular cortex. This is in a young child. It's very clear. You can appreciate that we have this endosteo margin, which is very distinct. This is very distinct. Okay, this is a normal trabecular pattern of the posterior mandible. So you can see the bony structure there. Yeah, that's the bone. Like it has many septa. And then we also have spaces. These are the bone marrow spaces. So we have that trabecular pattern. You can see the bony structure, and then within it we have those are bone marrow spaces. So when it comes to generalized uniform radiolucencies, so these are the pathologies that may occur in the bones. So what you find is a change in the size and the shape of the bone. And this is caused by generalized loss of the bone density. And this leads to the increased bone marrow spaces. So you're losing the trabecular bone, but then the bone marrow spaces, so they become larger. So That's what you have just said. You lose the bone trabeculation due to the changes in the number, size, and the orientation of the trabecular. So the trabecular bone, it will become, they will become fewer. They become fewer. Like if you lose the secondary trabeculation, then the primary trabecular bone becomes longer. It can become longer. Then the trabecular bone also can also become thinner because it's losing bone. So they become fewer, they will look longer, and they will look thinner. And then the cortical boundaries, they become thin and they lose density. This, for example, the inferior border of the mandible, as we have seen, the bony wall of the maxillary ear sinus, the mandibular canal, and the calvarium. Okay, so this is an example of a mandible where we have sparse trabecular bone, and we also have a thin eroded inferior mandibular cortex. Look at the mandibular cortex there. It's not well delineated like in the other radiographs that we have checked before. You can also see the marrow spaces. They appear a bit larger. You can see it's the bone pattern. It's looking a bit more dark. So the marrow spaces are larger, and the trabecular bone has reduced. So for you to really get to know whether anything has happened, like you have to know how a normal mandible looks like, then you can compare with this. Okay, so you can compare these two radiographs. So the top one, A, shows a male with a dense trabecular bone and thin inferior mandibular cortex. We can increase that. So not possible with that view. Okay. So we have the trabecular bone is quite dense, very dense. And then the mandibular cortex is also dense, and it's also, you can distinguish it actually. So if you compare with the lower image, this is a female who has a sparse trabecular bone and thin eroded inferior mandibular cortex. So looking at the trabecular bone, you can see it looks more darker, it's more radiolucent because it has more of the bone marrow than the trabecular bone. As if you compare it with the top one, where we have more bone, you can see dense bone. The trabecular bone is quite dense, but it is quite sparse in this image. Then looking at the mandibular cortex, the inferior border of the mandible, the top image, you can see it is distinguished, it is thick, but the lower image, this is thin. It is thin and quite light, it's eroded. Look at this again. This is a patient who had loss of bone density, and they also had thin mandibular cortex. So these are a child on HIV/AIDS therapy. This is due to the resulting effect to the vitamin D metabolism. So they end up with vitamin D metabolism disorder because of the AIDS therapy. So looking at this one, you can appreciate that we can't actually see the mandibular cortex, the inferior border of the mandible. We can't see the cortical bone. It almost looks the same as the rest of the bone. And the rest of the bone, it's looking more radiolucent. We have even lost the lamina dura around the teeth. And this is a generalized feature. So we lost the bone density. We also have the thin mandibular cortex. It is thin and has also lost density. So when we look at the differential diagnosis of a generalized uniform radiolucency, we can classify them as a common, uncommon, and then the rare ones. So the ones that are common is something like osteoporosis, cortisone therapy, rheumatoid arthritis, prolonged immobilization. They will all cause the thinning of the reduction in the density of the bone. So the ones that are uncommon will include Cushing syndrome, hyperparathyroidism, vitamin D deficiency syndrome, acromegaly, malnutrition, inherited anemias, leukemia, histiocytosis X, multiple myeloma, and osteogenesis imperfecta. Then we have in rare cases, like in hypophosphatasia, hypoparathyroidism, thyrotoxicosis, you can have that uniform radiolucency, also post-radiation changes. So we shall just look at a few examples, because at the end of the day, radiologically, they look almost the same. So let's look at hyperparathyroidism. What's the etiology? These are where we have excess parathyroid hormone, and this can result from tumors of the parathyroid gland, or if there is hyperplasia of the parathyroid gland. The other reason is if we have secondary hyperparathyroidism due to hypocalcemia. So if you have less calcium in the plasma, in the blood, then you have now hyperplasia of the parathyroid gland, so that you can have more of the hormones, so that you can try and balance that calcium. So signs and symptoms, you'll have generalized osteoporosis. This basically means a bone resorption, because you're going to lose phosphorus and calcium from the bone so that they can go to the blood. And then, so you end up with generalized decrease in bone density. At the same time, there's also increased renal reabsorption of calcium. Then you end up with the urinary tract stones. So it's possible that patients will have urinary tract stones, and if a clinician is not careful, they may just treat those stones, but not query where are these stones coming from. And probably if the same patient could have even an X-ray of the jaws done, probably one would notice that there is an issue with the bone. So the doctor has to go through that whole sequence of the calcium and the production and the hormones that are affected, for you now to exactly know what could be causing these stones. And then patients may also have giant cell tumor, which are called brown tumors. So what are the radiographic features? The cardinal signs, for example, in the skull, you'll have fine oval stippled pattern of bone, what we call the pepper pot skull. We look at an image that shows the same. Then you can have generalized osteoporosis and or osteopenia. So we have the thinning of the trabecular. Then they will become reduced in numbers in the mandible and in the maxilla. And then you can get a ground glass appearance of numerous small, randomly oriented trabecular pattern. Then you can have a unilocular or multilocular cystic radiolucency. These are the brown tumors. And then the absence of lamina dura. Then eventually can have calcification in soft tissues, for example, the kidneys, joints, muscles, subcutaneous tissues, salivary glands, etc. Other signs will include the absence of a radiopaque outline of the maxillary sinuses. Then you can have thinning of the inferior mandibular cortex, the mandibular canal, and the sinus wall. Then you can have saucer-shaped erosion of bone, and then loss of alveolar bone. Then granular appearing calvarium is caused by the loss of the trabecular bone from the diploid and the thinning of the corticotables. Then you can have also multiple intracranial opacities. So this is an image showing us a patient who has hyperthyroidism. So you're supposed to note the radiolucent jaws. You've actually lost so much of the bone. You've lost the calcium, the phosphorus. So you have more of the bone marrow. So the mandible is radiolucent. And this is actually even exaggerated by looking at the teeth. The teeth look like they really stand out because they are radiopaque. Then they don't lose their calcium. They remain the same, but the jaw has lost quite a bit of its bone density. Then you said you can have brown tumors. Look at that image there. These are radiolucencies there, just distal to the 3-5, which has been restored. So here we have a radiolucent lesion. Then we have also lost the lamina dura. It's more clear here. We have lost the lamina dura just next to the periodontal membrane space of that tooth. Then we have this saucer-like bone erosion. So this is now after the patient was treated, and we can see the bone is forming again. The area that looked radiolucent, now it's looking radiopaque. You can see the trabecular pattern there. And then there's also the reconstitution of the lamina dura. Now we have the lamina dura again. So the goodness is some of such a condition is that when it is reversed, the patient is treated, get back to normal. Even those brown tumors disappear. So this is another image to show you the brown tumor. So histologically, it just looks like the giant cell, the central giant cell granuloma. So it may be unicystic or unilocular or multilocular. So you have the multiloculation there. That's a radiolucent lesion, which is a brown tumor. So we can only get this through the histology, as well as working up also. Those are some of the systemic features, for example, checking the blood levels of calcium, checking the hormonal levels like the parathyroid hormone, then you're really able to tell why we are having such a lesion. So this is a pepper pot appearance of the skull. So this is where we have had resorption of the bone. So we have lost bone, and it's generalized. So you can see that it is everywhere. You can see the multiple radiolucent areas. I believe those are the areas that would look like the pepper, which is black pepper, that is. And then we have now areas that look radiopaque. That's where we have still some trabecular bone remaining. So you find multiple small radiolucent areas on the lateral skull radiograph due to trabecular bone resorption and loss of the bone and fibrous replacement. So the bone that is lost, then it is replaced by fibrous tissue, the bone marrow. Next, you can look at osteoporosis. So this is an abnormal porosity of bone. What is the etiology? There are many factors that can lead to this. Postmenopause, immobility, long-term steroid therapy, hyperparathyroidism, hyperthyroidism, and also due to diet issues. Then signs and symptoms, patient may present with back pain or pathological fracture, just fractures that occur. So easily, just a simple fall, and then somebody sustains a fracture, which can be actually multiple. So we are interested in the radiological features. So you have this generalized osteopenia or reduction in the bone density. Then you can have thinning of cortices, as we have seen that before, or the accentuation of primary trabecular. So the primary trabecular, they become prominent because you will lose the secondary, the trabecular bone. We look at an image that shows the same, or a diagram. So you lose the secondary trabeculation such that the primary trabecular looks larger. Then you have a granular bone in the skull because you have still lost quite some bone. So this is a diagram to show us a normal versus osteoporotic bone. Look at the normal bone. We have quite some a lot of bone there. The bone is dense, and you can only see these are minimal spaces. That's a bone marrow spaces. But now what happens with the osteoporotic bone? We have lost quite a lot of bone. We have lost a lot of bone. So you can look at the trabecular. So the trabecular actually looking long because we have lost the rest of the trabecular that cross and attach the primary trabecular. We have the other trabecular that forms later, and they will join all those primary trabecular, so they will even look like they are small or shorter. But now when we lose that secondary trabeculation, then the trabecular pattern, those septum, they look long than normal. So we have lost that bone. So the marrow spaces are quite huge. They are quite huge. So if such a patient falls, they can easily sustain a fracture. So this bone is very porous, very porous. So those are the stages of osteoporosis. So we are having the thinning of the trabecular bone. So we start now with the normal bone, and then now with time, we have now the marrow spaces are becoming larger because we are losing bone. So the trabecular bone becomes thin, and sparse. So it becomes thin, and the spaces, the bone marrow spaces become larger. These are filled with the fibrous tissues and all that. The other example is thalassemia. Here we have defective hemoglobin synthesis. So you end up having hyperplasia of an ineffective bone marrow. And other things that can occur is that, so when the maxilla is still growing and the other sinuses, you do not have the pneumatization of the paranasal sinuses. So the pneumatization of the paranasal sinuses is does not occur because now we are having this hyperplastic bone marrow. And then you have the expansion of the maxilla, so it ends up as a protrusive maxilla. The patient has what would look like a rodent-like face. Then you get jaws that are radiolucent jaws. So you have lost the trabecular bone, and much of what we have is the bone marrow. Then thinning of cortical bones again, and then this large coarse trabecular bone. You also have thin lamina dura, where you actually lose it. So this is a good example. Look at that axial view. At the area, at the level of the nose, you can see the nasal cavities, the nasal cavity there. Let's see. So this was the thalassemia major in a 10-year-old girl, and she presented with a nasal obstruction. So what we see is severe widening of the marrow spaces. The marrow spaces is quite widened. There is loss of normal trabeculation. So we have decreased bone density. You can see here the bone is very thin, and you can't actually see the sinuses. So the decreased bone density involving the maxillary sinus wall. So that's the sinus wall, which doesn't have bone at all, especially over here in some places. So you can see the radio-opaque border that we see in the maxillary sinus, because that bone has lost its density and become very thin. Look at the zygomatic arches. They're looking wide and they're just full of those marrow spaces and very retro bone. Again, the pterygoid plates over there, we have also lost the bony component, now looking radiolucent because of the bone, because of the bone loss and increased bone marrow space and the fibrous tissues within those spaces. So we have the medullary cavity expansion resulting in complete obliteration of the maxillary sinus. So we cannot see the sinuses because there was failure to pneumatize. And also when you have the medullary cavity of the walls expanding, they'll expand in such a way that even if you had the sinus, they'll become completely obliterated. Okay, this is an example of an image of a patient who has a thalassemia. This skull axial CT image shows remarkable marrow spaces expansion there. So with this, just need to compare with a normal one to realize that there is expansion. There is expansion of the diploic space over there. And then there's also cortical erosion, the cortical bone. The outer and the inner table, they are quite thin and not as prominent as they are supposed to be. Then we have this hair on head appearance, where we have the linear orientation of the trabecular bone. So you can see the trabecular bone. It's thin. It's thin and it is less dense. Okay, so that brings us to the end so we have just discussed a few of the examples, and you have noted that most of the features almost look the same. So for further reading, you can use the oral maxillofacial diagnostic imaging book by Alan Farman and Nolke and Wood, or the oral radiology principles and interpretation by White and Farroa. You can use Essentials of Dental Radiography by Waits and other relevant journal publications. Thank you.